Well, first of all, Dr. Fauci, what an honor. We're really so pleased to have you here today. And what an honor that you choose to come to Georgetown, come back to Georgetown at this time in your career. Our plan, we've talked a little bit in preparation, is to explore a number of different medical and scientific activities and to benefit from your experience over the last 50 years. I want to start also by saying that while you don't realize it, you were an inspiration for me. So I was fortunate enough to do my medical school and residency at Cornell New York Hospital, the same place that Dr. Fauci had done his, but you were there a little bit before me. But I remember very, very clearly being in Morning Report, sitting in that room, I think it was the 5th floor between Payson and Whitney Pavilion, and presenting, and it was in the early days. I was a resident in the early days of AIDS. And we would go through and present a patient, and Gordon Douglas, who was the chair of medicine at the time, pulled out an article and we discussed it, and then he turned to the wall, and in this conference room there's a wall of the chief residents. And he said, by the way, this paper is from that guy right there. And he was chief resident here. And it was from those early experiences that I recognized the importance, the value, the impact of science, and how, as much as I love being a physician and a clinician, the number of patients you could touch through science. So it was from those early days and role models like you that really pushed me to have science in my life. So on a personal level, thank you, Dr. Fauci.
Thank you.
So, everyone wants to hear your wisdom about medicine and science, but they also want to get to know you a little bit. So while we discussed a couple of questions I might ask, here's one we didn't talk about, just to get to know you a little bit.
Right.
What people really want to know, and they're really curious, what's on your playlist? What do you listen to when you're in the car? And is it true, secretly, you're a Swiftie?
My playlist, well, it absolutely tells my age. My playlist is the Beatles, the Bee Gees, and anything that's Motown.
All right. I love it. Thanks for sharing. Let's start at the beginning. Maybe you could share with us, where did you grow up, and how did you decide to become a physician?
Well, I was born and raised in Brooklyn, which in the next few minutes, that'll be very clear to you from my Brooklyn accent. It's probably started off with my family. My father was a pharmacist in Brooklyn, in the Bensonhurst section of Brooklyn. And back then, which was the 40s and the 50s, the pharmacist was different than CVS and Walgreens. The pharmacy was kind of like the pseudo-doc for the neighborhood for people who either couldn't afford to go to a physician or didn't think their problem was serious enough to go to a physician, or who needed marriage counseling, or who had a delinquent child that they wanted to know what to do with. So I just grew up from the time I had the age of reason as a child for service to the public. It wasn't a particularly economically sound profession then. He just barely made it. We were not at all a wealthy family. I would not have gotten through school if I didn't win scholarships. So I had that mindset that I wanted to do things for people, that it wasn't about making money, it was about contributing to society. Then I went through a series of Catholic education, which starting off with the Dominican nuns at Our Lady of Guadalupe in Brooklyn, who showed me less of public service than what's called tough love. I still have knuckles that hurt for things that you did when they would hit you with the needle, with the ruler on the nose. But it really started when I got my beginning of my Jesuit education. I went to Regis High School, which was a Jesuit high school in Manhattan. And it was very heavily weighted towards the humanities, towards classics, Greek, Latin, Romance language, with enough science to get you interested in science. So I was trying to figure out what I can do with my life that would be a combination of that real need to be people-centric as opposed to project-centric, at the same time that tickled my, I think, both interest and aptitude in science, which I was good at and I liked it. I liked the idea about the scientific process. Then I went on to another Jesuit school, Holy Cross, which actually even further manifested and actually had as their mantra, service for others. So it was literally started when I was a child and went up to then. So I figured the best way to combine my interest in science with my very intense training in the human species, be it the history of Greek classics and Latin and philosophy, at the same time that I could do something scientifically. So to me, the only career that I ever, well, actually I considered a career in basketball, but when I stopped growing it.
How tall are you, just for the record?
I'm 5'7". I was 5'7" in high school. I have some Schmall's note or something. I'm down to about 5'6" now.
Just stick with 5'7".
But I'll stick with 5'7". But I was quite a good basketball player in high school, and I really thought that that's what I wanted to do. But as I always tell the joke, which is the truth, I had a revelation that cemented my wanting to go into medicine, is that I was in New York City. It's a very competitive basketball city, and I was really quite good. I was a point guard, and I used to score a lot of points. And then I found out when I started playing against college players that a 5'7", very fast, good shooting point guard will always get wiped out by a 6'4", good shooting, fast point guard. So I decided it was medicine.
Good choice. Well, we need to find that point guard and thank him that he had you go into medicine. Do you still play basketball?
With my wife.
And what about, I mean, again, we're honored that you've come to Georgetown. It sounds like the Jesuit tradition and your education has been part of your life.
Yeah. Well, it was a question I asked myself when I had been, you probably know, I had been at the NIH for 54 years, and I was director for 38 years. So, you know, there comes a time when you have to sort of let go and let someone else take over. And I was toying with that right about the time as COVID was starting to taper down. And I was getting ready to step down, but then Joe Biden asked me to be his chief medical advisor. So I had known President Biden since the time he was a senator, and there was no way I was going to say no to that. So I stayed on for another 2 years. But during that time, I was asking myself the question, of all the things that I've done over the years, now that I'm still passionate, still energetic, and thankfully still healthy, what do I want to do for the next several years? What additional contribution can I make? And, you know, it wasn't doing another clinical trial or writing another New England Journal of Medicine paper. It was maybe, if I look what I am, a person who's, you know, of a certain age, who's been through a lot. I've had the benefit of, you know, advising 7 presidents, of understanding public policy and science. Maybe I could be an inspiration to younger individuals, medical students, residents, or even undergraduates, which was the reason why I have a joint appointment, both in the medical school and the School of Public Policy. And I wanted to go to a place that was the epitome of what I stand for, of service and integrity. And to me, Georgetown just rose to the top of that. As you know, Jack had, years ago, actually, Jack, I don't know how many years ago, but it was years ago, came to my office at the NIH and in a typical Jack fashion, without being very pushy, said, when you decide, whenever that is, of stepping down, would you consider Georgetown? And I said, well, of course I would consider Georgetown. But then when I was getting ready to step down, I got offers from a lot of schools that were not in Washington. You know, Stanford and Harvard and Cornell and Columbia and places like that wanted me to, because I wanted to stay in Washington, wanted me to have an office in Washington and go up and sort of give a lecture every once in a while there. But that's not what I wanted. I wanted to be with students. I wanted to be with residents literally on a daily basis. And to me, that, plus the fact of the profound connection I have to the Jesuit spirit of service, which has been my training throughout my entire life, not to mention the fact that my wife went to Georgetown. She got her PhD at Georgetown. I got married in Dahlgren Chapel. My 3 children were born in Georgetown Hospital, so I figured I think you got an edge.
So, you know, Jack gave a lovely introduction, and it's remarkable of the sheer number of things that you've done. And the accomplishments. And I've learned about some of the others. I mean, I understand that you were offered tenure at NIH at 29 years old, or something like that. What do you attribute to the secret of that success? Because it's one thing, a lot of us will be able to look back at our career and point to a single thing that they've done that they're very proud of, and they worked hard for it, but you have a lot of things.
Well, you know, Neil, it's very complicated. It isn't one thing. It's just a set of circumstances. When I finished my residency training and I went down to the NIH at the National Institute of Allergy and Infectious Disease, the institute that I stayed at, I had a really good mentor. I mean, I think I'm fundamentally pretty good. I can't say, well, you know, I was a dumb guy who had a good mentor. You know, I was pretty good, pretty smart. I was fundamentally a very, very good clinician. And I wanted to ask some clinically important questions. And my mentor put me on a project and asked me to figure out what an approach would be that might be worth investing a lot of effort and a lot of time. So he had a group of patients that had the disease we used to call Wegener's granulomatosis, which is now granulomatosis with polyangiitis and polyarteritis nodosa, who mortality was 100%, at least of the patients I've seen. I've never seen one of those patients survive. And it was clear that glucocorticoids was not the answer for these patients, because you could diminish the inflammation, but they died of renal failure and pulmonary disease. So we got the idea, and this is interesting, because I was trained in infectious disease, I was seeing a lot of infectious disease patients on the Cancer Institute ward, and they were getting, you know, CMAP and CPOP and all the different things, and they were getting infections that they called me to see as an infectious disease consult. So we got the idea that maybe we should take one of those cancer drugs that were given in gram doses and give it in milligram doses. And that's how we decided to give cyclophosphamide 1 to 2 milligrams per kilogram and monitor the white count so that it doesn't diminish below the dangerous level. And to our phenomenal gratification, we had 93% remission in a disease that was 100% fatal. So that was a good idea, the right place, a great mentor who put me on a project and gave me the leeway to do something very bold, because back then we were getting criticized for how could you treat a non-cancer patient with a cancer drug. And that started the whole paradigm, and that's the reason why I got offered tenure before I was 30 years old. You know? And then there was a decision about my career, about whether I was going to continue to do that or go back to just practice medicine. As I've told many of the fellows that I've seen, my whole purpose of coming down to be a fellow at the NIH was to get enough fellowship experience to go back to the New York hospital and practice medicine out of the New York hospital on York Avenue and 68th Street. That's all I wanted to do. But when I got to the NIH, I got that bug of what discovery could do and how it could be an amplifying effect of the impact that you could have on patients. And that's why I came back to the NIH after my chief residency and have been there ever since.
Yeah.
So it was a lot of things, Neil. It was luck, good mentor, all that kind of stuff.
A little bit of hard work in there, too.
Well, you know, I often say I'm a bit of a workaholic, and I used to apologize for it for my first 25 years, and then I decided I'm an unapologetic workaholic, and I am not the poster child for a good work-life balance.
You talked about a moment of courage that you took that made a difference. And in today's world, there's a lot more regulations, there's a lot more oversight, and we view things a little more holistically. I'm just curious, do you still see people taking those courageous steps, those innovative type of moves? We've got, phrase it a different way, we have a lot of people early in their career here.
Yeah.
And when they look at a career in education or research, it's often incremental.
Yeah.
But you kind of described a leapfrog approach.
Well, I think the example of the leapfrog thing I did that was risky at the time, but turned out history proved it was the right thing. When I came back from my chief residency in 1972, from 1972 to 1981 was when I was really on a real high, my career trajectory. We had first developed the therapies for granulomatosis with polyangiitis. Then we did the same thing for polyarteritis nodosa. We did some stuff for granulomatous, chronic granulomatous disease, immunodeficiencies. My career was on a high. Then in 1981, I was reaching a point where the big conceptual contribution was early on, and that everything else was good and fun and got you into all the right papers and all the right societies and all that. But it was a bit incremental as opposed to, transformational. So when the first group of patients who presented with this strange disease, curiously in all gay men, I tell the story very clearly that the first MMWR in 1981 in June was 5 gay men from LA with pneumocystis. And I thought it was a fluke. I said, this is going to go away tomorrow. Don't worry about it. And then 1 month later, the second MMWR was curiously 26, all previously healthy young gay men from not only LA, but from San Francisco and New York, who were presenting not only with pneumocystis, but with Kaposi sarcoma and with other opportunistic infections. And I remember sitting in my office. It was sort of like, one of those transformational things of a lightning bolt comes, and I said, this is a brand new disease. Yeah. And here I am trained as an immunologist and infectious disease guy to have a disease that epidemiologically absolutely is an infection. It doesn't have a name, it doesn't have an etiology, but all of these young gay men are dying. So a combination of my profound empathy for the people who were getting infected and dying and frightened and hopeless in some respects, to the fact that I felt my training was geared, if anybody's going to make contributions, it's me. So I decided on a dime that I was going to stop doing what I was doing and start admitting these desperately ill young gay men with this disease that didn't have a name and didn't have an etiology. The same mentor who recruited me to NIH and gave me the opportunity to make a reputation for myself, I remember his words. It's in my memoir. Yeah. Is that he said, Tony, don't give up your day job because this is probably going to go away. To his great credit, because he's a great man, when he saw what was happening, he said, you made the right choice. But people were reluctant to start studying this because they thought that it was a fluke and it was going to take away from other things we were doing. So that's when I made that bold change of changing the direction of my career, which people just couldn't understand. How could you do that? And I spent the next several years going from a physician who had developed a therapy for a formerly fatal disease. And all of my patients were saying, thank God you saved my life, you saved my husband's life, you're wonderful, you're a hero. Overnight, I went to admitting patients, almost all of whom died. So it was sort of like somebody turned a switch on me. I went from, being a hero that was saving lives to putting Band-Aids on hemorrhages and just being somebody who was trying to comfort people as they were expiring, trying to learn a little bit about the disease while you were doing it. And that was from 81 until we had good therapies. AZT was in 1987, but that kind of blunted a little bit, but people developed resistance almost always with a single drug, with an mRNA virus. But when we developed the 1996, the triple combination that started off with protease inhibitors, but now it's mostly integrase inhibitors and others, it's just, it's been the whole spectrum from darkness to just an amazing accomplishment.
And you've done it with so many diseases. I mean, you've shepherded this country through not just HIV, Ebola, Zika, swine flu, I mean, the long list. And while we don't have time to go through all those, if you look back, if you could give me almost like a one-liner, from the HIV experience, what I learned in life is X, Y, and Z. Or from Ebola, what I've learned in life is this.
Yeah, I mean, what I learned in life about emerging infectious diseases, which, I put myself in a position to respond, and that gets to really the next bold change. I'm fundamentally, my identity as a physician, as a researcher, and I saw there wasn't much attention or resources paid to HIV to my satisfaction. So I really, the last thing in the world I wanted to do was to be a science administrator. I just wanted to continue just to see patients and do research. But when the job of NIAID director opened up, I saw that as an opportunity to catapult the field of infectious diseases, and particularly HIV, to the level it deserved because of the institutes. When I became director of NIAID in 1984, the total budget for the institute was $360 million. When I left, it was $6.4 billion. So if I were in industry, I would have been a great parachute. And what I learned from HIV and what I learned from Ebola and what I learned from pandemic flu is that when you get an emerging disease, you've got to get the best minds and jump all over it from the beginning. Because emerging infections, they putter along and then they do this. That's exactly what HIV did. When HIV first came, it was a disease that we only saw symptomatic people who were advanced in their disease because those were the only ones that went into the hospital. When we got a test to do screening, it was like somebody hit me with a Mack truck. Yeah. It was that when we started screening people, it was clear that the patients that we were seeing were the tip of the iceberg. And we did a screening in Greenwich Village and in the Castro district, and it just completely floored me. I almost couldn't believe it. 50 to 60% of the gay men in Greenwich Village in 1985 were already infected with HIV. Wow. 50% of those in the Castro district, maybe 60%, were already infected. So the enormity of that made me say, I got to go do something. That's when I said, I'm sorry, but I'm going to be the NIAID director. And that's what I did.
And I've heard you talk also, 40 years ago, you were doing health equity research in many regards. Maybe you could tell us a little bit about the health equity lens back during this time.
Well, back during that time, it was a combination of health equity and patient advocacy. Mm-hmm. And that was one of, I think about the 2 or 3 things I did that were, I was sort of alone in it and didn't have much backing, was to embrace the activist community. Fundamentally, 98% were just young gay men and some injection drug users. And one of the problems was back then that when we were doing clinical trials, we did not, as scientists, understandably but incorrectly, felt that we as scientists and physicians know what's best for the patient without much input from the patient. The regulatory authorities knew what was best without input, and there were very strict entry and exclusion criteria for clinical trials. There was no concept of compassionate use or an alternate way. So the gay community predominantly started to try and get the attention of the scientists, who every time they did, the scientists would push back until they became very provocative, disruptive, and all of the demonstrations that some of you may remember. And you know, one of the things I did that I think was one of the better things that I've done in my life was to, you know, get back to the Jesuit training and kind of put aside whether a person was confronting you and just listen to what they were saying. And they were making absolutely perfect sense. And I said, you know, if I were in their shoes, I'd be doing exactly what they were doing. I would be disrupting society. And so I listened to them and brought them into the dialogue of how you design a clinical trial, loosen the regulatory. I mean, and it wasn't easy because the scientific community was not happy with me. They thought I was selling out science, and I wasn't selling out science. I was trying to make science better. The WHO was totally pissed off with me when I was doing that. I mean, they really were very, very angry. And when I went to San Francisco in the late 80s and proposed a parallel track to make drugs available outside of the clinical trial for people who did not qualify for the clinical trial, so long as it wasn't held against the clinical trial data. So you could have two parallel things. You could have a pristine clinical trial, but you could have drugs available for people. And the FDA, understandably, I'm not blaming them, they were totally against it. So I got up in San Francisco at a meeting, and a very iconic guy named Marty Delaney, you shouldn't know who he is, but interesting, he was a Jesuit scholastic who left the Jesuits, was a gay activist who was trying to do this. And I immediately related to the guy. I mean, he was Jesuit trained. How am I going to not listen to what he said? He told me, go out and just advocate for this parallel track. Yeah. And I did. And I thought it was going to be quiet, you know. I'm talking to an audience of mostly gay guys. It made front page of the New York Times the next day. And I thought I was going to lose my job because the FDA was crazy. They were talking about, you know, what is he doing? He's a cowboy. He's doing this. So my relationship with President George H.W. Bush, who I had become really good friends with, I remember I came back and I flew back on the red eye from San Francisco, and I got a call from the White House from John Sununu, who was the chief of staff of George H.W. Bush, saying, and I had known George H.W. Bush because I had shown him around the NIH a few times. He said, Tony, the boss wants to know what's going on. And I said, this is really the right thing to do. And I got a phone call about a few hours later, and he says, I spoke to him, he says, fine, go ahead and do it. Yeah. As soon as he said, go ahead and do it, the FDA said, we were with Tony all along.
That's a great start.
It's true.
You've worked with 7 presidents, and you know the world is filled with all kinds of negative stories and cynicism about politics. But tell us, I mean, there's a kernel of good there. It sounds like there was a president that listened to your advice.
Yeah, no, 6 out of 7 did. So the PEPFAR program that George W. Bush asked me to go to Africa to do, I think we need to remember that. You know, I have completely stayed away from politics. Everybody knows that. You know, I'm not a political person. I'm not a Democrat. I'm not a Republican. I'm a scientist, and that's all I want to be. But when I hear people talk about, Republicans this and Democrats that. The Republican Party right now has been hijacked by a bunch of people who are, well, I don't need to describe them, But the people in the George H.W. Bush and the George W. Bush administration, even though you could disagree with them ideologically, that they may be a bit too conservative on one thing versus another, but at least there was integrity, honesty, and a respect for institutions. So that it is interesting that George W. Bush, who was a very conservative guy, was responsible for sending me to Africa to develop a PEPFAR program that saved, 25 million lives for people who were disenfranchised and in a country that didn't have the resources. That's a pretty progressive thing to do, isn't it?
Yeah.
So we better be careful, when we're judging people. It's, you can be conservative and do some really good things, but if you're completely wacko to what we're seeing right now, that's different.
So look, we're in a world, I know. We've got a room full of people that believe in research and education. We grew up in the scientific methodology as the way to create knowledge. Look, 500 years ago, people were saying the world was flat. It was probably only 100 years ago that we stopped using leeches. The scientific method has done us well and created contemporary medicine. But the trust in science has been undermined. And I'm just curious, you've lived in the center of this. As you look at our current situation and the lack of trust, what do we as an academic health system, we as a Jesuit university, we as the future leaders of medicine, what do we need to do? How are we going to overcome this?
Well, it's not going to be easy because there isn't one thing to do, because the mistrust in medicine is part of a broader trend that's going on that's reflected by the profound divisiveness in our country. I mean, if you have any interest in the history of our country, this level of divisiveness I've never seen before. And like I said, I have the perspective of having advised 7 presidents of the United States. And even when I was advising very conservative Republican presidents and very liberal and progressive Democratic presidents, there was a consistency there of honesty and truth. And even though I may differ from you ideologically, I at least respect their opinion. Right now, we have such profound divisiveness that anything that smacks of authority telling you what to do, if it happens to be someone who is in a different tribe or a different camp, it's almost like we have different tribes that don't speak to each other. So that's an introduction to the answer to your question is I'm not really sure what we can do except continue to do what we do and articulate the importance of evidence, data, truth, and science. We can't do any more than that because then there's going to be a lot of people that don't believe us. It just seems to me crazy. There are very good studies now to show that whether or not you believe in vaccines and get a vaccine and save your life is very heavily weighted towards whether or not you're a Republican or a Democrat. That's the craziest thing I've ever heard, that more Republicans are getting serious disease and dying from COVID than are Democrats. Just think about that for a second. That is absolutely crazy, but it's happening. The other thing is that I get, as a scientist, I get very disturbed at is the normalization of untruths. As I've often said, is that, years ago, I say years ago, when even back when I first started doing this, if you'd said something that was egregiously untrue, and it was then proven to be egregiously untrue on tape or on something you wrote, that you would be disgraced and that would be the end of you. Now, there is so much untruth and conspiracy theories that, you know, all of a sudden, truth is a confusing thing. You know, what is truth? If you can say whatever you want to say, and if you put it on social media, it becomes the truth to tens of millions of people. That's an extraordinary phenomenon, Neil, where you can make up something completely crazy. The election was stolen. Boom. 25 million people believe it, and 75% of a certain political persuasion believe it. I mean, that, I don't know about you, but that really scares me. Yeah. That you can get so many people to believe something that's so obviously not true. So when you say, what can we as scientists do about the anti-science? I wish I had a clear answer for you, except to say, don't give up. Because the people who are spreading misinformation and disinformation are very energetic. And as I always, somewhat tongue-in-cheek, but not quite, say it's almost as if they don't have a day job. Whereas all of us have important day jobs, so we can't be, you know, fighting back on a one-to-one basis. But we can't give up and just say, well, that's the way it is. We have to keep talking about in clear, articulate ways what scientific data and scientific facts are.
We're coming to the end of our time. Again, we have a room filled with people early in their career. The future leaders of healthcare are in this room. We would love to hear any final advice that you have for them.
Yeah, I mean, we're fortunate enough to be in a profession that just what we do is almost inherently associated with a profound degree of gratification and satisfaction. So, you know, I think we're lucky. You know, that doesn't mean that anybody outside of the medical profession isn't doing really good things, but there's something inherent about when you get up in the morning and you go to work, and whether or not you're a basic scientist or a supporter of a scientist or a clinician who's involved in seeing patients every single day, or someone who's supporting a scientist or supporting a physician. That's something that I think is precious. So we should be thankful that we had the opportunity to do that. Yeah.
Well, we're thankful that we had the opportunity to talk to you today. We're very grateful that you have come and you're going to be able to be a part of the Georgetown MedStar community. As you could see here today, we've got a lot of energy, enthusiasm, creativity, innovation, and we're becoming a role model, I think, as an academic health system. You and I had the fortune to train in places that were great academic medical centers, and I'm excited that you're going to be part of our journey into the future of academic medicine. Thank you for being with us.
Thank you. Thank you. Thank you. Thank you. Thank you. Thank you. Thanks. Thank you.